Hi friends, today our topic is drugs acting on bone. There are mainly four different types of cells present in bone tissue. They are osteoblasts, osteoclasts, osteocytes and osteogenic cells. Osteoblasts are concerned with bone formation. Osteoclasts are concerned with bone resorption or dissolving the bone. Osteocytes are mature osteoblasts. They are mechanosensors. They respond to mechanical stress by a small protein called sclerostin present in them and send signals of bone formation or bone resorption to the bone surface to modify their microenvironment and thus regulating the mineral homeostasis. Osteogenic cells develop into osteoblasts. The continuous process of bone breakdown and formation of new bone, that is the metabolic process of bone resorption and bone ossification, is known as bone remodeling. In response to low blood calcium levels, the parathyroid hormone, interleukins and active form of vitamin D, that is calcitriol, activate osteoblasts to form ligands, which are protein substances known as rank ligands. And for these rank ligands, receptors are present on osteoclasts known as rank ligand receptors. These rank ligands go and bind with those rank ligand receptors on osteoclasts, and then the osteoclasts get differentiated and activated, and then they get converted to ruffled bordered. Then they start damaging the bone. The damaged bone then releases some factors like bone morphogenic proteins, prostaglandins and insulin like growth factors, which in turn stimulate osteoblasts. The stimulated osteoblasts go to the site of bone damage and initiate bone formation. Effect of hormones on bone. Estrogen plays an important role in the growth and metabolism of bone. It is the key regulator of bone metabolism in both men and women. It protects the bone from resorptive effects of parathyroid hormone. During bone growth, estrogen is needed for proper closure of epiphyseal growth plates both in males and females. Estrogen blocks new osteoclast formation and it also induces apoptosis of osteoclasts. Estrogen is a sex hormone that is essential for the maintenance of bone health in females because it promotes the activity of osteoblasts, that is, the cells that produce bone. When estrogen levels drop during menopause in women, osteoblasts are not able to effectively produce bone. The deficiency in estrogen levels in postmenopausal women induces bone loss and causes osteoporosis. Calcitonin is a hormone produced by parafollicular cells or C cells of thyroid gland. It regulates the levels of calcium and phosphate in blood, thus opposing the action of parathyroid hormone. That is, it decreases calcium levels in blood by two mechanisms. First one is it inhibits osteoclasts, which are the cells responsible for breakdown of bone. When bone breaks down, it releases calcium into bloodstream. Actually, osteoclast activation, that is the release of calcium into the blood, is seen with parathyroid hormone. Here there is opposite action with calcitonin. That is, osteoclast inhibition with calcitonin reduces the amount of calcium released into the blood. However, this inhibition is short-lived. It can also lower the resorption of calcium in the kidneys, leading to low blood calcium levels. Hence, the main aim of calcitonin is to lower calcium levels in bloodstream. The drugs which act on bone are Denosumab. It is a human monoclonal antibody. In postmenopausal osteoporosis, When all the other drugs are ineffective, this drug is given. It is also used in treatment of giant cell tumor of bone and in treatment of hypercalcemia associated with hyperparathyroidism and malignancy. It is also used in prevention of bone metastasis as seen in prostate cancer. Mechanism of action. Denosumab works by blocking a protein called rank ligand. It is a rank ligand inhibitor. It blocks rank ligand from binding to receptors on osteoclasts, thus inhibiting osteoclast activity, which is bone resorption. Hence, bone resorption is reduced and bone mineral density is increased. It is administered subcutaneously for every 6 months. Side effects include transient hypocalcemia, particularly if there is vitamin D deficiency, and blisters of skin at the site of injection, red, dry, itchy skin, muscle pains, joint pains, pancreatitis, dermatitis. As they lower bone resorption, bones become brittle and hence get fractured easily. Hence it causes femoral fractures. Contraindication is hypocalcemia. And it is given for 3 to 5 years. Next class of drugs is bisphosphonates. These are analogues of pyrophosphates and they contain two phosphonate groups. Hence they are called bisphosphonates or diphosphonates. Two phosphonate groups are linked to a carbon atom that replaces oxygen in pyrophosphates. Mechanism of action of bisphosphonates is they inhibit bone resorption. Bisphosphonates act in two ways. One is by stimulating apoptosis of osteoclasts, thereby reducing osteoclast number, finally reducing the bone resorption. And second and third generation BPNs inhibit cholesterol synthetic pathway, thereby lowering the osteoclast function, leading to reducing bone resorption. Therefore, there is reduced risk of vertebral fractures. Bisphosphonates are classified into three generations: first generation, second generation, and third generation. First generation bisphosphonates are least potent, and third generation bisphosphonates are most potent drugs. First generation bisphosphonates are non-nitrogenous BPNs. Second and third generation BPNs contain nitrogen in their structure and are called amino bisphosphonates. Here all bisphosphonates drugs name end with the word dronate. Drugs which come under first generation are etidronate, teludronate and clodronate. Drugs which come under second generation are alendronate, ibandronate and pamidronate. Drugs which come under third generation BPNs are risidronate and zolidronate, which are more potent. Drugs used for oral use are alendronate, ibandronate and risidronate, and for IV use zolidronate and ibandronate and pamidronate are used. Zolidronate is the most potent and the longest acting drug among BPNs. Etidronate acts on Paget's disease. Paget's disease is a disease that disrupts the replacement of old bone tissue with new bone tissue. Etidronate is also used in hypercalcemia. Pamidronate is used in Paget's disease, hypercalcemia with malignancy, prevention of bone loss in breast cancer and multiple myeloma. Alendronate is used in Paget's disease, hypercalcemia of malignancy and hyperparathyroidism. It is given mainly in glucocorticoid induced osteoporosis. Zolidronate is used in prevention of osteoporosis in patients with prostate and breast cancer who are receiving hormonal therapy. Side effects of bisphosphonates. Oral bisphosphonates, as they are poorly absorbed by gastrointestinal tract, they can cause esophagitis, esophageal irritation, heartburn, abdominal pain and diarrhea. Bioavailability is less than 1% for amino bisphosphonates and it is decreased with food intake. Hence, it is recommended to take these drugs on empty stomach with a big glass full of filtered water and to remain upright for at least 30 minutes. Other side effects of bisphosphonates are osteonecrosis of jaw, which is rare and it is due to long-term high dose usage in bone metastasis and hypercalcemia. And the other side effect is hypocalcemia and it is more with the more potent drug, that is zoledronate, which causes seizures. Pamidronate has flu-like reactions and the risk of bone fracture, that is femoral chalk stick fracture, is seen with BPNs. Next class of drug is selective estrogen receptor modulators, that is SERMs. These cause tissue selective actions. They produce beneficial estrogenic effects on bone and liver and prevent harmful estrogenic effects on breast tissue. Estrogenic actions of tamoxifen and laroxifene are, both of them have same action on bone, that is they reduce the risk of fractures and bone resorption, and also on liver they have same action, that is they reduce the levels of LDL and total cholesterol in blood. There is increased risk for deep vein thrombosis and pulmonary embolism with both the drugs. The only difference is tamoxifen causes endometrial proliferation, whereas laroxifene has no effect on endometrium. Anti-estrogenic effects are, both the drugs cause vomiting and hot flushes, and tamoxifen and laroxifene both reduce the proliferation of breast cancer cells. Indications of SERMs. Clomiphene is used in vitro fertilization in both male fertility and female infertility. Male infertility and female infertility. Tamoxifen is used in prevention and treatment of breast cancer. Bezodoxifene is used along with estrogen in prophylaxis of postmenopausal osteoporosis with intact uterus, and raloxifene is used in prevention and treatment of osteoporosis in postmenopausal women. The side effects of SERMs are: clomiphene causes nausea and vomiting, hot flushes, PCOD, multiple pregnancies, ovarian hyperstimulation syndrome. Tamoxifen causes nausea, vomiting, hot flushes, increased risk of deep vein thrombosis, pulmonary embolism, and endometrial cancer. Raloxifene causes hot flushes and increased risk of deep vein thrombosis and pulmonary embolism. Next class of drugs is calcitonin analogs, which is salcatonin. This drug has the same effects similar to calcitonin. It is used by intranasal route in osteoporosis prophylaxis and subcutaneous routes in Packett's disease, and it also has analgesic effect in vertebral fractures. Side effects are hypocalcemia and hepatic carcinoma, and with nasal spray the side effects are irritation of nose, bleeding from the nose, that is epistaxis, and headache. Next class of drugs is parathormone analogs. Teriparatide is parathormone analog and abaloparatide is parathormone related peptide analog. The mechanism of action is, first they do bone resorption, that is osteoclast activity, and then they do bone formation, that is osteoblast activity. Here bone resorption is only transient effect, it doesn't last long. So hypercalcemia is seen in the beginning and later it will not be seen. And here for bone formation calcium is required, so calcium supplements are given along with teriparatide and abaloparatide. And these drugs are administered through subcutaneous route for treatment of osteoporosis in males and postmenopausal women, and in severe osteoporosis who have high risk of fracture, and in treatment of bisphosphonates induced femoral chalk stick fracture. The side effects of these drugs are hypotension, pneumonia, and osteosarcoma. It is contraindicated in Paget's disease because Paget's disease itself causes osteosarcoma, and the duration for which these drugs are given is 2 years. And next class of drugs is strontium rallinate. The strontium rallinate is formed by strontium metal and rallinic acid. It acts on both bone formation and bone resorption. It is indicated in osteoporosis. The mechanism of action is, the structure of strontium is similar with calcium. That is the reason for the in place of calcium, strontium goes to bone matrix and increases the bone formation. Here osteoclasts can remove calcium from bone generally, but not strontium. As they cannot remove strontium, there is decreased bone resorption. Thus strontium granulate inhibits bone resorption and promotes bone formation. Next, plicamycin, which is formerly known as mithramycin. Plicamycin is an antibiotic produced by the bacterium Streptomyces plicatus. It lowers calcium levels by inhibiting the effect of parathormone, thus reducing the bone resorption. It is indicated in Paget's disease and rarely in hypercalcemia. The route of administration is intravenous, and it has got toxic effects on liver, kidney and bone marrow, causing hepatic injury, bone marrow suppression, thrombocytopenia and epistaxis. And the last class of drugs is Romosozumab. It is an anti-sclerostin monoclonal antibody which increases bone formation. It is approved by FDA in 2019 as new treatment for osteoporosis in postmenopausal women who are at high risk of fracture and in whom all the other therapies have failed. The route of administration is subcutaneous, and the duration of use of this drug is limited to 12 monthly doses. The drugs acting on bone can be classified into drugs inhibiting bone resorption, drugs increasing bone resorption, and drugs acting on both bone resorption and bone formation. Drugs inhibiting bone resorption, as seen before, are also known as anti-resorptives, and the drugs which belong under this group are Denosumab, Bisphosphonates, calcitonin analog, SERMs and Plicamycin. PTH analogs, that is teriparatide and Romosozumab, increase bone formation, and the only drug which acts on both bone resorption and bone formation, that is inhibiting bone resorption and increasing bone formation, is strontium rallinate. The common side effect with anti-resorptives is hypocalcemia. Hence, calcium supplements are given along with anti-resorptives. Thank you friends. For more videos, please subscribe to my channel.